So the final thing just to dwell on is the cardiovascular responses. And we referred to this momentarily when we looked at that kind of peak height velocity, and we showed that kind of shuttle run test data. But let's just have a look at it in a little bit more detail. Well, one of the primary factors in terms of cardiovascular responses and cardiorespiratory endurance is the stroke volume. And as within adults, we see the same response, that you get stroke volume rises by about 30 to 40% initial stages, and plateaus and remain stable at around about 50% VO2 max. It's exactly what we see in the majority of adults. In highly trained adults, we know that stroke volume will actually rise to its peak at VO2 max. We know, though, if we look at kind of the actual acute response of the heart, left ventricular and end diastolic size slowly declines as cycling intensity increases, implying that ventricular preload does not substantially change as cardiac output rises. That's the same as we see in adults. But fundamentally, the difference between adults and children is the morphological structure of the heart. It's much, much smaller in the child. So the volumes that are being produced are proportionally lower. But the operation of the heart, in terms of the way it responds to exercise, is identical to that of an adult. Well, what about things like blood pressure? Well, we know mean arterial pressure rises by about 20 millimeters of mercury. Cardiac output increases about 4 times above resting values. Exactly the same as you see, again, in a healthy adult. So the key thing is the responses are the same for children as they are for adults. It's the values that are significantly different because they have a much, much smaller blood volume in children, a lower hemoglobin concentration, the same kind of hematocrit concentration. Plasma volume will be lower. The net result is they have a smaller cardiac output, a smaller stroke volume, but their AVO2 difference, which is the proportion of the blood that's been extracted at the muscle, is the same. The proportion of the blood that's being directed to the tissues as a function of the cardiac output is the same. It's just that the volumes are lower, which explains why VO2 max is lower in children compared to adults. Okay, so if we look at heart rate data, okay, and this is pre-pubertal endurance athletes. Don't forget, these are athletes. These aren't untrained. So if we look at these, we've got males and females, we've got different sports. But look at this. These are resting heart rate values. Okay, athletes, here's your non-athletes. Okay, interesting, right? These are pre-exercise. So these aren't resting values. These are pre-exercise. So what do these indicate for us? Well, they indicate for us in some instances what's called an anticipatory response. There's no real difference here. Lower here, lower here, slightly lower here, lower here, lower here, lower here. Why have you got this? Why is it higher in the athletes than here? It may be this what's called an anticipatory response, that they're anticipating what is coming and heart rate is raised. But on the whole, the heart rate's low. And remember, they're resting, but they're kind of pre-exercise. So there is that potential for the anticipatory response. But lower heart rates. So they have a greater cardiovascular range over which they can work. We know that particularly in younger children leading to adolescence, their maximal heart rate is higher. The heart is having to beat harder. Why? Because they've got a lower cardiac output volume than they have compared to an adult. So the net result is the heart beats faster to compensate for that lower volume, despite the fact that actually, the kind of the energy cost of doing work is the same between those two population groups. And then if we just look at this data, this is quite nice data from Jack Wilmore's lab. It's really for the old data set, but it's quite useful. So again, we've got our boys and our girls. This is our hemoglobin. So the hemoglobin concentration, when you compare boys to girls, is pretty similar. But look at the changes as you go into adulthood. Both males and females have increased, but males actually proportionally have increased more in hemoglobin concentration. Now look at left ventricular mass. So this is the mass of the left ventricle of the heart. Boys already have a larger heart compared to girls, but look at the proportional increase, significantly greater. And you go, well, why would that be the case? Well, fundamentally, you've got a larger body, a larger shell in terms of height and the mass, which means you would have an increase in blood volume. You've got the increase, although only small, but you've got the increase in hemoglobin concentration. Because you've got an increase in blood volume and you've got a greater muscle architecture to oxygenate, the left ventricle has to adapt both both eccentrically and concentrically to increase the pumping capacity of the heart, to increase those demands at the tissue. Remember that overall, again, we just look at our data when we compared, men to women, and look at the data up here, significantly different in men to women compared to it was boys to girls, reflecting that increase in overall physical characteristics in terms of height, mass, and so on, all of which needs to be oxygenated. If we look at kind of this data, this is stroke volume index in boys, and what you've got the data for sitting. I don't worry about the sitting data so much, but this is kind of the response to exercise, his sitting and his kind of supine. So this is sitting exercise and supine exercise. The response is uniform. This is exactly what you would see in an adult population group. The key thing is, it's the volumes. The volumes are significantly reduced compared to what you'd see in adults. And the same here. This is the stroke index, well-trained cyclists compared to untrained. Again, the volumes are reduced. These are actually getting closer because these are quite well-trained cyclists, but they are reduced. But notice both groups in stroke volume are producing that plateauing-like response. And again, the systolic, the diastolic responses, the untrained, this is the degree of distillation and the degree of systolation that we're witnessing. So it's the degree of change centimeters wise. Again, uniform in both groups compared to what you'd see in adults. And then this final data set, this is taken actually from Andy Jones's lab down at Exeter. And what they've got is trained and untrained, and then they've got pre-pubertal, pubertal, and post-pubertal. And if we just look at a little bit of the data here, and so I just want to look at cycle ergometry. Don't worry about upper body ergometry for the moment. Look at the cardiac output. So the cardiac output increases if we take our, let's take our untrained, pre-pubertal. Look at the increase, 14.8 to 17.5 litres per minute. And 17.5 actually doesn't really change when we go to post-pubertal. This is, again, reflection of that growth spurt that we've been talking about. If you look at the kind of the peak stroke volume, so here's your stroke volume peak, 76 millilitres. And the untrained pre-pubertal, pubertal, it's increased to 91. Now it's increased to 98. So one of the things that starts to happen is the cardiac output. Why is it that the cardiac output hasn't really changed, but the stroke volume has changed? Well, let's look at the heart rate response. Here's the pre-pubertal untrained, 195, 192, 190. So the heart is becoming more efficient because the pumping capacity is increased, the heart rate has decreased. If we then look at the extraction of oxygen at the muscle, which is the AVO2 difference, so in milliliters of oxygen per deciliter, 12.2 at pre-pubertal, 11.7, 12.6. So this isn't changing. So the amount of oxygen being extracted and beat to the heart hasn't changed. What is changing, which then helps to explain the increase in the VO2 max, is the cardiac output as a response of 1, the increase in hemoglobin concentration, 2, the increase in blood volume, 3, the eccentric and concentric hypertrophy of the heart, and they all contribute then to that VO2 max and are all fundamentally linked to the fact that during pre-pubertal to pubertal, you've got the growth spurt. You've got more muscle mass or greater volume of muscle mass that needs to be perfused with oxygen.